Good afternoon, everybody. Thanks for making the time to join us today. I'm really excited to introduce one of my colleagues from the Yale School of Medicine. Dr. Hall is an assistant professor of medicine with Yale Cardiology. She's the associate program director of the program for biomedical ethics at the Yale School of Medicine, and also leads our preclinical undergraduate student course in regards to their learning for things in regards to cardiovascular medicine and disease, for which she does a great job there as well. But she wears many hats, and today she's going to be talking to us about something in the cardio-oncology realm, where she also has a specialty clinic, and we'll be talking to us about the cancer therapy-related toxicities that could go along with or I guess what can cause heart disease in patients that are receiving different forms of chemotherapy. So, Dr. Hall, thank you so much for taking the time, and please take it away.
Well, thank you so much for that very kind introduction, Dr. Beasley. And thank you for inviting me to speak to you all today. I will say that even though this is technically in a lecture format, I very much encourage questions early and often. So feel free to interrupt. Sometimes I don't see questions on the chat. So typically, if I see a question in the chat, I will assume that's a question to be answered afterwards. But if you have a burning question, or if there's something I'm saying that's not clear, I certainly don't mind if you unmute yourself and just kind of blurt it out, because that's how I like to give lectures in person. I like them to be super interactive. And if you have a question, probably someone else has that question too. So you're doing everyone a favor by asking it. And you're also making me better by forcing me to be better at explaining things both today and in future lectures. So with that being said, let's get started. I have no disclosures. I have no conflicts of interest to disclose. This is the QR code to the pre-lecture survey. There are a few questions there, multiple choice questions, and then I've listed the link here. And my recommended resource for this talk is the 2022 ESC Cardio-Oncology Guidelines. I provided that link in an email to the organizers, but if you just Google 2022 European Society of Cardiology Cardio-Oncology Guidelines, you will find it. It's not hard to find. So with that being said, let's get started. And I'm sorry, I'm on the cusp of losing my voice, so I apologize, but I think I'm going to be able to muster it through the next half hour or so. So the objectives for this talk, first, I'd like to make sure that we're all on the same page with regard to the definition and both the practice and the rationale of cardio-oncology. I want to make sure that we understand the interplay between cancer and cardiovascular disease. The main point that I was tasked with conveying to you all today was to know at least some of the various chemotherapy agents and other cancer-targeted therapeutic agents associated with the risk of heart failure. But I should mention that that list is constantly growing, and to give a lecture of this time and to be completely comprehensive is going to be nearly impossible. So I've chosen to focus on some of the most important and most common ones. But you can see the ESC guidelines they're like over 100 pages, so they're very comprehensive. But this is basically just meant to be a primer to help you think about and be familiar with some of the agents that you may encounter. And finally, I want to make sure that you come away from this understanding some of the key principles in the prevention, the evaluation, and the management of cardiac complications of chemotherapy. All right. So I like to think of cardio-oncology as something, and really kind of an umbrella term that encompasses the prevention, the screening, and the treatment of cardiovascular disease and its associated risk factors, very importantly, before, during, and after cancer therapy. So it's a very broad field, as you likely know. Also, in terms of the rationale of why is cardio-oncology such a growing and increasingly important field? Well, because as cancer survivorship continues to improve, and it does so really dramatically, particularly with the advent of immunotherapy and some other newer targeted therapies, we're really seeing better and better cancer survivorship, which is awesome. But on the flip side of that, that means that the salience of patients' cardiovascular health continues to increase because it's increasingly important in terms of its influence over patients' overall longevity as well as on their quality of life. And so, when cardio-oncology is working as it should, really that entails both the cardiology and the oncology teams taking care of a patient, working together with the goal, that sort of a dual goal, that patients receive both the best possible treatment for their cancer and also that they're optimizing their cardiovascular health and they're mitigating cardiotoxicity. So I really want to emphasize that the goal isn't, of cardio-oncology, it's not to create barriers to receiving chemotherapy or other cancer therapy because we're so worried about the cardiac risk, but rather it's to anticipate and mitigate cardiovascular complications so that we can allow patients to receive the most effective cancer therapy. So that's that. All right. So I also think it's really important to underscore the interplay between cancer and cardiovascular disease. Of course, as you all know, these are the number 2 and number 1, respectively, leading causes of mortality in the United States and in most places in the world. They do have multiple shared risk factors, and these include lifestyle habits, toxic exposures, and many other risk factors that often converge through the common pathway of inflammation. So, this includes things like an unhealthy diet that's high in processed foods and red meat, which have been linked to increased inflammation, a lifestyle that is sedentary, more prone to obesity, which also the central adipocytes are metabolically active and have been shown to secrete pro-inflammatory cytokines. Sometimes it's genetic factors. Sometimes it's things like CHIP, clonal hematopoiesis of indeterminate potential, which has also been linked to both cancer and cardiovascular disease, probably through a pathway of inflammation. Toxic exposures. This can include both lifestyle habits like smoking and alcohol consumption, and can also include toxic exposures through the environment, such as air pollution, water pollution, contaminated water supply, etc. Also, we know that malignancy itself can be a risk factor for cardiovascular disease because malignancy is associated with both inflammation and oxidative stress. And we know that these factors tend to promote both accelerated atherosclerosis as well as thromboembolic disease. You can also have direct tumor invasion of cardiac structures. This is in the case, obviously, of very regionally advanced or metastatic disease in the chest, and that can directly mechanically impair myocardial or valvular function. That's less common than some of the other issues that I brought up. We often see neutropenia in the setting of hematologic malignancy or as a result of chemotherapy, even for solid malignancies, and that can increase patients' susceptibility to sepsis, which in turn, because of the catecholamine surges, can provoke atrial fibrillation and stress-mediated cardiomyopathy. So these are things that we see not uncommonly. And finally, excuse me, malignant effusion from advanced chest malignancy, typically with breast, lung, or breast or lung cancer or lymphoma, but we can also see it with advanced metastatic disease in the chest. In these patients, they often have malignant pleural and pericardial effusions, and this can lead to pericardial tamponade or refractory pleural pericarditis. And so, even before we get into the cardiotoxicity of cancer treatment, it's important to understand that, again, cancer and cardiovascular disease share a lot of risk factors. So patients with cancer may already be at elevated risk for cardiovascular disease via these shared risk factors. And then the cancer itself is also a risk factor for cardiovascular disease. So we're not starting from an even playing field. So now jumping into kind of the main focus of this talk, an overview of the cardiac complications of cancer therapy. I'm going to start sort of with a very broad overview of how we think of these. So first, I'll briefly touch on what are some of the cardiac complications of chemotherapy and other systemically administered therapies. And this includes the one that most people, I think of first. This is sort of how the field of cardio-oncology started by looking at anthracycline-induced cardiomyopathy, which is manifested as LV dysfunction, cardiomyopathy, and at times clinical heart failure. But it's not just anthracyclines that can cause this. We can see this with trastuzumab, which is a HER2-targeted therapy for breast cancer and sometimes gastric cancer. We can see it with a lot of the tyrosine kinase inhibitors, which are other targeted therapies. We can see fulminant myocarditis in the case of immune checkpoint inhibitors, which we will talk about later as well. Arrhythmia, typically we associate that most commonly with, which we can see with 5-fluorouracil, thrombosis, which is a very significant concern with ponatinib and nilotinib, other TKIs. hypertension, classically associated with vascular endothelial growth factor receptors, but factor inhibitors, excuse me, but can also be seen with other agents as well. And then pulmonary hypertension can be seen with dasatinib, also called Sprycel. You've probably heard of it. And this can cause effusion and edema as well. And so even though cardiomyopathy is sort of the canonical cardiovascular complication of cancer therapy, it's really not the only one. And so you need to keep sort of a wide differential when you're thinking about the potential cardiac complications. In addition, we can see other complications of cancer therapy that are not related to chemo or systemic therapy. So I've recently started adding this to some of my talks because I've seen it now so many times, and it can often cause really big problems, even if it's just a lot of distress to the patient. There have been times where it's led to a lot of extra imaging that could have been avoided, with maybe more diligent reporting and observation. But the issue of central venous catheter associated right atrial thrombus. So, ideally, as you know, when you have a central venous catheter, the tip should ideally be right at the cavo-atrial junction between the SVC and the right atrium. But sometimes that tip can migrate either because of position changes the patient or weight loss that the patient has while receiving chemotherapy. And so sometimes that catheter tip can migrate into the right atrium. And if that catheter tip migrates so far that at times it abuts or touches the opposing free wall, that really creates a huge nidus for thrombus, because not only do you have the pro-inflammatory state of malignancy, you also have that direct kind of mechanical injury from the catheter tip. And so we see this a lot, right atrial thrombus, sometimes even tricuspid valve, depending on the angle of how the catheter tip goes into the right atrium. And so now you're committing patients to anticoagulation, which sometimes is challenging, especially if they have chemo-related neutropenia, thrombocytopenia. And it also, again, is just very stressful to now the patient, in addition to having a malignancy, has a blood clot in their heart. Already patients with malignancy are often at increased risk of venous thromboembolic disease like DVT and PE. Now that risk has gone up. So what's the point of all of this? It is to say that these patients are often getting a lot of echoes. Obviously, the catheter tip placement is verified with fluoroscopy, typically when it's placed by IR. But if you're an echo reader and you see a patient undergoing chemotherapy or some other systemic therapy, and they have a port and that tip is way in the right atrium, pick up the phone and call the oncologist and say, like, hey, I think that catheter tip is in too far. Because it's much easier it's a little bit of a pain to coordinate with IR to get them to pull the catheter tip back, but it's a lot bigger of a pain and a lot more of a risk if that catheter stays in there and then the patient comes back with a thrombus. So, be really fastidious when it comes to that tip placement. Again, this is more sort of for echo readers, but make sure you comment on that. Don't just say, oh, catheter in right atrium, okay, that's where it's supposed to be, moving on. You really shouldn't be seeing much of that catheter tip in the atrium because it's supposed to terminate at the cavo-atrial junction, as I said. All right, I'll get off that soapbox. Moving on to radiation therapy. So radiation cardiovascular toxicity often manifests late, often 5 to 10 years after receiving radiation, although sometimes it can manifest earlier. Typically, it manifests as fibrotic disease, so that can happen either to the pericardium or the myocardium, leading to restrictive cardiomyopathy or constrictive pericarditis. It can also accelerated CAD, less through the classic atherosclerotic pattern and more through a sort of fibrotic pattern that leads to stiffening and stenosis. And you can also see radiation valvulopathy arise because of fibrosis and thickening and retraction of leaflets. And so those are all things to sort of keep in mind. So moving on, we're going to do a little bit of a deeper dive into some of these individual therapies and what their cardiotoxicities are. So as I referenced before, I'm heavily drawing from the 2022 ESC guidelines on cardio-oncology, and I would refer you to that for further detail. I think it's just worth noting here, I include this image just to emphasize a few points. Number one, that we really think of patients as being in like sort of three different stages. There's the baseline risk. So if it's a patient who has some cardiovascular risk factors already and they're about to undergo potentially cardiotoxic therapy, it's really important that we see them, if possible, before chemo is started. Sometimes it's going to be very time dependent, and that's not possible. But to the extent feasible, it's helpful to do a baseline risk assessment and get all of those risk factors optimally controlled with medical therapy before starting. Then there's the period during cardiotoxic cancer therapy itself, which often entails very close monitoring. And then there's the survivorship period, which hopefully extends decades and decades. But sometimes, particularly as I noted with radiation therapy, but sometimes with other therapies as well, you can see late toxicities. So it's important to understand that just because patients have completed cardiotoxic therapy, it doesn't mean they're necessarily completely out of the woods, and aggressive risk factor management is still important during that time. And I'll also draw your attention to the concept of CTR-CVT, or cancer therapy-related cardiovascular toxicity. This term is starting to eclipse the older term of CTR-CD, cancer therapy-related cardiac dysfunction, which typically, that's a term that refers to specifically to LV dysfunction as a result of cardiotoxic therapies. But as I mentioned before, cardiovascular toxicity from cancer therapy extends far beyond just cardiac dysfunction or LV dysfunction. All right, this is a very busy slide, and my point is that not to go through all of it, but just to sort of show a list of, these are some of the potentially cardiotoxic therapies that the ESC chose to highlight in this document. And so you can see there are quite a few of them. We'll be going through many of these. And it's also worth noting that, again, it's really important to employ aggressive prevention strategies as indicated. So, sometimes that means minimizing the use of cardiotoxic drugs in very high-risk patients, although that does have to be balanced against what's the risk of not using a cardiotoxic agent if that's really by far the best agent to treat a really aggressive cancer. So that's not sort of a binary decision of is it safe or isn't it safe, but it's really a risk-benefit discussion, as is almost everything else in medicine, frankly. And then, there are also preventive strategies that we can employ, which includes beta blockade and RAS blockade, of course, just like GDMT in heart failure in general. And then, there's also more and more emerging evidence of the protective effect of statins, probably through their anti-inflammatory benefits. Sorry. So we'll start off with anthracyclines. So anthracyclines, again, that's sort of the classic thing when people think of cardiotoxicity. Examples include pretty much all of these agents that end in rubicin. I'd say probably doxorubicin is the one that we encounter most in our practice. These act through multiple cytotoxic mechanisms. And, since this is a talk for cardiologists, not for oncologists, I'm not going to really deep dive into the molecular mechanistic details here, but just try to give you a very broad sense. These agents commonly used to treat breast cancer, lymphoma, leukemia, and sarcoma. As you know, as I've mentioned, they can cause cardiomyopathy and lead to heart failure. And there are several risk factors that have been identified that increase a patient's risk of developing cardiotoxicity, and these include higher doses. So doxorubicin or its equivalent greater than 250 milligrams per meter squared, concurrent radiation therapy, particularly if it's more than 30 grays of exposure. And of course, that's radiation therapy to the chest, such as radiation for left-sided breast cancer, left-sided lung cancer, mantle radiation for lymphoma, et cetera. Age greater than 60, pre-existing cardiac dysfunction, and some other classic risk factors for cardiovascular disease in general, like smoking, hypertension, hyperlipidemia, and obesity. So, in addition to classical GDMT, this cardiotoxicity may be mitigated by an antidote called dexrazoxane, or by using a liposomal formulation of doxorubicin or another agent, although this is usually something that's at the discretion of the oncologist based on their perception of to what extent that may impact the efficacy of the patient's cancer therapy. Trastuzumab. So this is a monoclonal antibody that targets the HER2 receptor, which is expressed in certain breast cancers, or I should say overexpressed in breast cancers, and sometimes in gastric cancers as well. The vast majority of patients that we see receiving trastuzumab are women undergoing therapy for breast cancer. But again, it can be, like I said, it's not exclusive to breast cancer. Like anthracyclines, trastuzumab can cause cardiomyopathy and lead to heart failure. The risk is increased by receiving anthracyclines concurrently or recently, and also by advanced age, pre-existing coronary disease, and again, hypertension and hyperlipidemia. Usually, if it's detected and treated in a timely manner, it's reversible with timely neurohormonal blockade, or again, what we typically use for GDMT and heart failure. And so we have a really low threshold to start these patients on beta blockers and ACE inhibitors, or angiotensin receptor blockers in particular. Fluoropyrimidines. So these include 5-FU, which is an IV formulation, and capecitabine, which is an oral prodrug. These are antimetabolites that work by causing DNA damage and interfering with RNA function. Excuse me. Typically, they're used to treat breast cancer, gastric cancer, pancreatic cancer, and colorectal cancer. And the main toxicity that they're known for is coronary vasospasm, although they can also cause myocardial toxicity as well. The risk for coronary vasospasm or coronary ischemia may be increased by baseline coronary disease or prior concurrent radiation therapy. But I say maybe because it's not really fully understood which patients are going to be at higher baseline risk for this. And it's maybe less the baseline coronary disease puts them at higher risk of having this reaction to 5-FU, but rather makes the consequences of 5-FU vasospasm likely to be more dire because they already have less vasodilatory reserve. And so more work needs to be done in that space, but it's worth noting here. And typically, if patients do experience classic anginal symptoms that we think are suspicious for 5-FU related coronary vasospasm. If that is by far the best agent to treat their malignancy, it's not unreasonable to retrial under a monitored setting. So typically we'd like these patients to be admitted to telemetry and monitored. So if they experience chest pain, they can notify someone right away, and we'll give them nitrates and or calcium channel blockers to prophylax against it. And this is often a very effective strategy, and patients can often, although not always, receive fluoropyrimidines with this strategy. So again, we anticipate we mitigate the cardiotoxicity. That's a common theme here. Osimertinib. So this is an epidermal growth factor receptor, or EGFR inhibitor, again, also under the umbrella of tyrosine kinase inhibitors. It's used to treat non-small cell lung cancer. It can cause cardiomyopathy and heart failure, as well as prolonged QTc. This too is something that can sometimes be retrialed at a lower dose cautiously if you can get LVEF recovery. So I several years ago, when this drug wasn't as well understood, I had a patient who was on osimertinib. She had a really precipitous drop in her EF to I want to say on the order of 30%. But she completely recovered after the osimertinib was held, and we started her on neurohormonal blockade. And we in close conversations with her oncologist, who felt that it really was necessary. This was by far the best agent to treat her lung cancer, wanted to retrial. So we retrialed at a lower dose with really aggressive neurohormonal blockade, frequent echo monitoring, and she actually did great. Like, she did not have a recurrent drop in her EF. So again, there are ways to sort of get around this cardiotoxicity, even if it happens. And she ended up living a lot longer than we might have initially expected with that degree of cardiomyopathy and that advanced a lung cancer. So VEGF inhibitors. So the examples of VEGF inhibitors include bevacizumab and naxitinib, but there are quite a few of them out there at this point. These are anti-angiogenic genesis agents. So basically, in order for for tumors to grow and to expand, they need a blood supply. And so anti-angiogenesis agents work by limiting their ability to create that blood supply. These agents are typically used to treat gastrointestinal or genitourinary malignancies, as well as non-small cell lung cancer. Classically, severe hypertension is the thing that we worry about the most in these patients, although they can also cause LV dysfunction or heart failure. Typically, we'll treat with agents including beta blockers, calcium channel blockers, ACEs and ARBs, and nitrates, things that we expect to have more vasodilatory effects. So when I say beta blocker, I'm implying non-selective beta blockers that have alpha blocking activity, because you want to sort of help to promote vasodilation. So, there isn't going to be as much of a role for diuretics in these patients, although we may need to reach for them in really refractory cases. And I also would just underscore that there's often a big need for close monitoring these patients to titrate these agents adequately, because it's often not just to like set it and forget it. Okay, this is your regimen, you're good. Sometimes these therapies are stopped and then resumed. When they're withheld, sometimes patients' blood pressure will plummet. And so they require frequent follow-up for titration. Even if you're not able to do that as a cardiologist, being really available to discuss with oncology so that they can call you and you can talk about how best to titrate their regimen can be really helpful. Bruton tyrosine kinase inhibitors, an example of this is ibrutinib, used to treat hematologic malignancies. Again, the sort of classic cardiotoxicity we associate with this is AFib, but it can also cause hypertension, CHF. We typically prefer beta blockers for rate control in these patients, given the category D interaction that ibrutinib has with diltiazem and verapamil. And apixaban and rivaroxaban are preferred for anticoagulation, given that there's a potential interaction with dabigatran and there's an increased risk of intracranial bleeding with warfarin. And part of that is just because the bleeding risk of patients on this agent is already increased because of the platelet dysfunction that it causes. Proteasome inhibitors include bortezomib, which is a reversible agent, and carfilzomib, which is irreversible. It's used to treat multiple myeloma. And carfilzomib in particular can cause a lot of different cardiotoxicities, including hypertension, pulmonary hypertension, and LV dysfunction. It's less commonly seen with other proteasome inhibitors, but it's not impossible. And then immune checkpoint inhibitors. I think most people are familiar with these at this point. In the last probably 5 years, there's been a lot of press about them. So these include pembrolizumab, ipilimumab, nivolumab, atezolizumab. There are a lot of other newer agents out there as well, used to treat a really wide variety of cancers. And they work by unleashing the immune system against the cancer itself, but they can also, as an off-target effect, unleash the immune system against any organ or system, and that includes the heart, which of course then leads to the entity known as ICI myocarditis. The presentation of ICI myocarditis can be there's a very broad spectrum of asymptomatic to absolutely fulminant disease. So as you can see here, it's staged or it's graded grade 1 through 4, where you have patients who are completely asymptomatic, and then patients who have life-threatening cardiogenic shock. And then, we often ask the advanced heart failure folks, such as yourselves, to help us in managing these patients. And these are some management strategies suggested by the ACC that, depending on the grade of toxicity, sometimes we don't need to be super aggressive. For really mild toxicity, it's reasonable to hold the checkpoint inhibitor and monitor patients, as opposed to grade 4 toxicity, where we really would be not only do we hold the ICI, we'd be very reluctant to retrial it. And these patients often require really aggressive immunosuppression regimens, as you can see here. So in terms of pharmacological approaches to prevention, a couple little pearls. Can I just ask how much I have a lot of stuff to potentially talk about, but I want to be mindful of time. Can you give me a sense of how much more time I should talk versus?
We're at the top of the hour, so we
Okay.
usually conclude around this point in time.
Okay. So try to wrap it up.
Okay.
All right, good to know. Sorry, everyone. I thought I would go through this a lot more quickly, but shocker, I am wordy and I like to go into a lot of detail. So a couple pearls. I included a little bit of content about shared decision-making at the end, which I'm going to skip for the sake of time, but I do want to just make a few points about pharmacologic approaches to prevention, and just note that it's really important not to discontinue or de-escalate medical therapy for cardiovascular disease and its risk factors just indiscriminately when initiating cancer therapy. I don't think that's done very much anymore, but 10 years ago, it was not uncommon to just stop patients' antihypertensives and statins if they were undergoing cancer therapy, because it was like, let's just, eliminate the possibility of interaction. Let's just focus on the cancer and we'll deal with that stuff afterwards, because, the hyperlipidemia is a chronic issue. The hypertension is a chronic issue. But, as we've really learned that poorly controlled risk factors for cardiovascular disease increase the risk of cardiotoxicity. So that's something that we want to be very mindful of. as I mentioned here. Some meds may require adjustment due to interactions with systemic therapy. So often that means, perhaps changing atorvastatin or rosuvastatin to pravastatin because prava has fewer interactions. So even though it's not a high intensity statin, if that's what allows us to continue a statin at all, we don't make perfect the enemy of the good. Meds also often require adjustment as people's weight and PO intake fluctuates, and their baseline blood pressure and insulin sensitivity may respond. And then for hypertension, we typically will prioritize cardioprotective therapies and deprioritize calcium channel blockers, except in the case of 5-FU and VEGF inhibitors, as I mentioned, and thiazide diuretics, because often these patients have not as good PO intake because of the anorexia that comes with a lot of cancer therapy. And then they're more prone to dehydration. Lifestyle interventions are really important in these patients. I'm not going to belabor them, but we need more data specifically in the cardio-onc population, but there's a growing body of evidence that supports whole food plant-based nutrition as a really powerful tool in preventing both cancer and cardiovascular disease, as well as treating its risk factors. We also know that deconditioning profoundly impacts many patients undergoing cancer therapy. So it's really important to emphasize exercise early and often in these patients. And when we're evaluating and managing CTR-CD, there are a couple pearls that I want to leave you with as well. One is to avoid anchoring bias, right? So just because a patient's undergoing chemotherapy with a potentially cardiotoxic agent, and then they're presenting with cardiovascular symptoms or imaging abnormalities, you don't want to necessarily assume that it's that agent and just stop it and end there. You need to also keep in mind, as I noted, cancer and cardiovascular disease share a lot of the same risk factors. So, you need to take coronary artery disease off the table. You need to take some of these other potential issues off the table and not just assume it's the cancer therapy. And so these patients deserve a full workup just like any other patient would. It's important to understand the role of permissive cardiotoxicity. As I alluded to before, if someone's EF drops marginally, but they have no symptoms, and to withhold the therapy that we think is responsible would have very adverse effects for their oncologic prognosis. Often we'll just monitor very closely, aggressively titrate medications to allow them to get through their treatment. And that's where, the importance of medical and supportive therapy comes in, as well as, the importance of shared decision-making with these patients, because sometimes it's not an easy call, and the medical facts alone don't really give us the answer, and it's really important. It's always important to elicit patient goals and values and priorities, but particularly in this field where there are so many different factors that play. I'm going to skip these slides on shared decision making and communication because of time constraints, and then this is my last slide. So just a few key points. Cancer and cardiovascular disease have multiple shared risk factors, and malignancy itself, as well as its treatment, can increase the risk of cardiovascular disease. The baseline screening for the optimization of cardiovascular health and its risk factors, as well as monitoring during and after treatment, can mitigate the risk of cardiotoxicity, applying both pharmacologic and lifestyle interventions. And clear communication with patients and other clinicians is really important to establish both medical facts and patient preferences in order to promote effective shared decision-making and optimize patient-centered outcomes. Thank you so much.
Well, thanks so much, Dr. Hall. We have a question for you in the chat, so I'll start off with that one. So once you start using guideline-directed medical therapy, I'm assuming this is for a patient, with like a chemotherapy-induced cardiomyopathy, would you continue the GDMT indefinitely, even if left ventricular function improves while on therapy?
That's a great question. Thank you so much for this. So, as is so often the answer, I would say it depends, although I would say usually yes. And the reason is multifold. Number one, if you look at the general cardiology literature, that the data would suggest that any patients who have previously had a decrement in EF are going to be at higher risk for a future decrement in EF, compared with patients who have always had a normal EF. And so a lot of what we do in cardio-onc is extrapolated from the general cardio-oncology literature. So that's the first point. The second point is that we know that often cancer therapy, cardiotoxic cancer therapy, can have late toxicity that can arise years after receiving the therapy. Although typically we do expect to see most toxicity arise within the first year, with the exception of radiation therapy, as I noted. And so, but again, that has to be a shared decision with the patient. So I think it's really important to be honest about the limitations of our knowledge, which is to say, I can't tell you that if we stop this medication, something terrible is going to happen. Like, it's very possible that if we stop it, your heart function is going to be fine. And then it's also possible that even if we continue it, you'll still have a heart issue down the road. But then there's the third possibility, which is that if we continue the medication, that your heart function will remain fine. And if we stop it, it will decline again. And so, in the first two scenarios, what we do doesn't matter. And in the third scenario, what we do does matter. So we really want to kind of optimize the chances that you're going to have normal ejection fraction or preserved as to the extent possible by keeping you on these medications. Now, this, though, is going to be dependent on the patient preferences and the tolerance of the medication. So, particularly in like young, lean, fit women who already start out with like a low heart rate and low blood pressure, and then they undergo, cancer therapy for breast cancer, and then they develop chemo-related anorexia, and then they lose weight and they're dehydrated. They often don't tolerate neurohormonal blockade very well. Feeling lightheaded and dizzy are understandable side effects of this. And in patients like this, where their EF might just drop marginally on trastuzumab, and then it recovers, and they really desperately want to get off the medication because they just don't feel great on it. They feel okay, but they just feel better off of it. I mean, that's very reasonable then to consider stopping it and to monitor them closely. So that has to be a decision that we make with the patient. We obviously make our recommendations. I think it also depends on how low their EF went. If their EF was 20%, I probably would be a little bit more nervous about stopping the medication than if it dropped to 51% from a baseline of 58%. I don't know that there's specific evidence to make me think that. That's sort of my sense based on the severity of the disease they had and my worry of its returning.
Do any of the drugs you use cause orthostatic hypotension and tachycardia?
Sure. So actually, often we see not so much the tachycardia, but any antihypertensives, we can see orthostatic hypotension if it drives the blood pressure too low. The one that I think is the worst offender is diuretics. So I hate using thiazide diuretics in these patients. Most of the time, again, it's going to depend. Sometimes patients will have some like venous stasis and a little bit of edema, and even though that doesn't treat it, the root cause, it gets better on it. So, so again, these are not categorical statements, but as a general rule, I've seen the most issues with patients having trouble tolerating thiazide diuretics. So I usually try to switch them off the thiazide onto a beta blocker or an ACE inhibitor or angiotensin receptor blocker before starting therapy. But there's the potential for orthostatic hypotension with any. It's just, I think with diuretics, it's the worst because you already, often these patients have decreased PO intake and dehydration as a result of the cancer. We often see tachycardia in patients with kind of aggressive malignancies, whether that's because of just an increased metabolic and catecholaminergic state or autonomic neuropathy that comes from some cancer therapies. It's something that we see not uncommonly, this inappropriate sinus tachycardia. And after, we do an appropriate workup, by making sure, that they're not febrile or infected or have hyperthyroidism, et cetera. I have a low threshold to start beta blockers in these patients, and particularly patients where I suspect malignancy-related inappropriate sinus tachycardia. They often derive a lot of symptomatic relief from beta blockade. And one of them includes actually just feeling a bit calmer. Obviously, it's not a true anxiolytic agent, but it does blunt the physiologic manifestations of anxiety, and cancer is a very anxiety-provoking diagnosis and condition. And so I have a lot of patients who love their beta blocker and actually wouldn't want to stop it because it just smooths things out for them a little bit. And again, with the idea that if we leave them, tacking away at 100, 110 beats per minute indefinitely, even if it is, there's no clear underlying cause, are they going to be at increased risk of tachy-mediated cardiomyopathy? I don't know that there's a study that answers that question definitively, but I like to err on the side of if they can tolerate it and they're not having any ill effects from being on metoprolol, I do like to keep them on it, especially if they've received cardiotoxic therapy.
Are there any other questions from the group? I have a couple, Sarah. <laughs> So I'm just going to
Go
ask them,
for it.
and then I got to jump and go see a patient. So
Okay, sorry I took so long.
no, it's okay. It's quite okay. So first off, things I'm always confused about is, let's say you're having somebody who you're seeing in clinic with no, and maybe you don't get these, maybe you probably do get these consults. You know, somebody doesn't have a history of cardiomyopathy, but they're being started on a cardiotoxic agent, I guess.
Mhm.
And you showed us the slide there about preventative therapies in regards to different drugs that could be considered. I guess what would be your, just in summary, what would be your recommendation for um, drug therapy to prevent chemotherapy-related cardiomyopathy? And then what's the most recent kind of recommendations for imaging in regard to one, pulling the trigger to start more aggressive guideline-directed medical therapy, looking for any signs of LV systolic dysfunction? Are we still
Mhm.
looking at strain? Are there other imaging modalities? And if we are looking at
Yeah.
strain, what's the cutoff to kind of make us want to do that?
Sure, sure. So, so yes, the main imaging modality that we rely on is echo. But when echo is not of great quality or is sort of a borderline call, we typically will have a low threshold to get a cardiac MRI to get a better look. We do still use strain, and typically, the strain, the amount, if there's a greater than 15% relative reduction in the absolute value of the strain, that's what we consider to be concerning for early cardiotoxicity. And so that's sort of the number that we look at. So it's more sort of what the strain is less negative than negative 17%. It's probably abnormal. The other thing I will say is that, strain is very tracking dependent, and if you have garbage in equals garbage out. And so if you don't have good endocardial definition on the echo images, the strain often doesn't track very well. So I always, when I see a drop in strain reported, I always go to look at the images and make sure it looks like it's tracking appropriately, because that's something that's important. If there's a drop in strain though, and there's no drop in the EF, that would almost never be a reason to stop the therapy, and rather would be a reason simply to initiate aggressive neurohormonal blockade. With respect to sort of and then to answer in terms of like what's the imaging frequency, for a lot of these agents, it's every 3 months an echo's recommended, but that's also going to depend, and the ESC guidelines have these tables depending on like the risk of the patient and how much. So I would refer you to that to sort of look at some of the most updated recommendations, but it's going to depend. So a patient who's been on Herceptin or trastuzumab for years because for metastatic breast cancer, and it's kept it at bay, I'm not getting an echo every 3 months. I will probably extend it to every 6 months if it's normal. Just because that's a big it's a big ask to ask someone to get 4 echoes a year for 5-10 years. And so whereas someone who had a significant change in their echo, and we're initiating aggressive neurohormonal blockade because we're worried about early cardiotoxicity, I might increase the frequency to every 6 weeks or every 4 weeks while we're initiating that, just to make sure there's no further decrement. So there's a lot of role for clinical judgment there. And to answer sort of the first question, I'm answering in the reverse answer you asked. We just have a very low threshold to initiate cardioprotective therapies. So, if someone has no risk factors, if they have like absolutely pristine blood pressure, total stone cold normal EKG, they're supposed to get a baseline echo before most of these therapies anyway. So, we want them to have that before they start so that we know what we're dealing with. But we probably would not initiate cardioprotective therapies then, because they may be less likely to tolerate it if they're starting out with a lower blood pressure. And so the risk may be higher, and then the benefit may be lower as well, because they're going to be at lower risk of developing that toxicity. But even if someone's blood pressure is like 131/79, and I look and it's been like hovering right around the 130/80 mark at recent visits, I'm probably going to try to convince them to start on a beta blocker or ACE inhibitor, depending on what their heart rate is. Even though in a general cardiology situation, the guidelines would suggest, and in my own practice, I would say, hey, let's focus on lifestyle interventions right now to try to get that blood pressure better, because that it would seem a bit premature to start medical therapy at that time. So we have a really low threshold to start, but I'd say if everything is absolutely pristine, I probably wouldn't start them on therapy, unless there were an indication to do so. But I try to find any possible one.
All right, well, thanks so much. I'm getting the sign that my patient's calling for me, so
Oh,
I'm gonna.
sorry.
No, no, you're good. You're good. So I'm gonna log off. But thanks so much, Dr. Hall, for taking the time to
Thank
visit
you.
with us. For everybody, these lectures will be available on YouTube. Please spread the word. And again, thanks, Dr. Hall, for your great presentation.
Thank you for the invitation. I really appreciate it.
Bye bye.
Bye, everyone.